All right, welcome back, everybody. We're going to be talking about operative vaginal delivery. And so what this is what's better known as vacuum and forceps delivery. Now, we'll go over questions. Why do we need them? Indications, prerequisites, reasons to do it, reasons not to do it, here in this episode. Hello and welcome to the New School OBGYN podcast, the podcast in women's health, but for everyone. Our goal is to promote good and reliable knowledge because the source of your information matters. My name is Eric Schmidt. I'm a board-certified OBGYN. And today I have with me, again, Dr. Olga Valieva. Please consider downloading and following along. We're in all the major podcast hosts, and check us out on YouTube for the video podcast. I also have other videos up there now if you want to check that out. Again, vacuum forceps.
Hi, friends.
With Dr. Valieva.
We're trying not to make it a vacuum versus forceps, but it might turn into that.
No, yeah. We'll try to stay civil to each other in this one.
I have no what's the word? No skin in the game?
Yeah.
What's the verbiage?
Well, it sounds scary. I think that's the first impression I get with patients when we're talking about labor itself. Is, especially if it's first labor, is very scary, unknown, all those things. And so hopefully we can shed some light, some reassurance, and hopefully you can have a better idea of these situations going into your delivery. So hopefully you're not listening to this for the first time right during your delivery.
Should we play this for people at the hospital?
We could.
All right. So why do we do this?
Well, Olga, Dr. Valieva, why we would choose to do a vacuum or a forceps. We'll just say vacuum as general right now.
Okay.
Why would we choose to do a vacuum?
Operative delivery?
Vacuum is more familiar with patients,
okay.
I think, or salad tongs as far as forceps. That's what Becky calls it.
Yes.
So why do we do it's to expedite delivery. And there can be a few scenarios behind that. It could be because of a concern about baby. It could be a concern with mom. It could be mom has been pushing for 2 hours and is exhausted and just needs a tiny touch of help. And so those are kind of the main reasons why we would choose to do the vacuum or forceps. We'll throw an image of each of those items up on the YouTube video so people can see them. But I think one of the biggest questions and one things to discuss with patients is there any risk?
Oh, absolutely.
And what patients' options are.
Yeah.
Clinical scenario.
Sure.
First time mom, full term, normal growing baby suspected, coming in labor. And she is in complete pushing, baby's in a good position, and everything seems to be going correctly. It's just she's been pushing for 2 hours. It's her first time, which that's definitely not uncommon. And she's just exhausted, and she tells you, Dr. Olga, can you help me? And so that's a scenario that can be there. And so, the options that we have to help are the vacuum and the forceps.
Or C-section.
And so that's kind of our options at that point. Continue pushing because things are looking good again. Vacuum, we'll talk about the risks here in a second. Forceps, same. Or C-section. We talked about C-section before in the podcast, so we have a little idea of what to expect with that. But it's a major surgery. So these options are developed to hopefully reduce the risk, reduce the number of C-sections.
Right. And, it's not without risk, right? Everything we do, any kind of operative procedure we do comes with risk, right? So
Every delivery.
When you put it that way, geez, Eric.
I'm not trying to be doom and gloom. I'm just saying.
With operative delivery, there is both risks to mom and to the baby. I know people typically think of was it going to hurt my baby, right? But
generally the first concern.
The first question, right? Which is,
valid and a mom.
So we have to talk about both. So I don't do forceps, not because I hate them, but because I just didn't train in them. And yes, Eric and I trained together, but I have what some would say a white cloud where it just never happened. I put forceps on once in residency. It just never came up, and I just only trained on vacuums, so that's what I'm comfortable doing. But So as far as the risks of a vacuum, most commonly, so the way the vacuum works is you put essentially a suction cup on top of the baby's, kind of like on top of the cone. There's specific locations to put it. And then we pull as mom pushes or the birth parent pushes, so that it's not just the provider pulling, it's kind of a concerted effort together, right? So you're helping, you're assisting the pushing effort, right? It's not just me doing all the work. So most common complication, if you will, is usually the baby will have a little bruise on the top of the head, kind of like a very big cone, which will go away, and a bruise, which will go away. Less likely,
well, the baby's going to have a cone from the delivery
right,
anyway. I think I've seen some pictures online, like, oh, my baby had a vacuum. Look at the head. But that's actually just the...
show you Pete's head. Minus the vacuum, pull through. But yeah, I mean, you might just get more swelling, a bruise, which is the most common situation. Less likely, but also possible, is lacerations or cuts over the scalp, just because of how much, not necessarily traction, but just the force of the vacuum. We have to pump it up to a specific pressure, right? And that can cut the skin. Other complications, there could be retinal hemorrhages, so little blood vessels. Like those are rare, but they can happen.
Yeah, those things. And then there's the big bad scary thing of like a hematoma, whether it's under the skin or even in the potential
in the brain. So, but those are like, depending on the study, it's like 1 in 6 to 800 potential brain bleeds, and those are incredibly rare. But when they compare them to C-sections, sometimes those already existed just from the pressure of the contractions and just from pushing. So it's hard to say, like, is it because of the vacuum or is it because of the birth, right? And then potentially, and this goes both for forceps and for vacuum, is we pull the head up, but then the shoulder gets stuck, right? The shoulder dystocia. Right. With forceps specifically, just because we're putting the blades not on the top of the head, but over the face, there could be potential damage to the nerves of the baby's face. There could be more bruising over the face. There could be imprinting. Does that happen? Like we can see, but it's temporary, right? But really
it's
more concerning
like
is
vacuum
like
causes the
cone. But really, it just those are the risks to the baby.
Yeah. Well put.
And mom risks.
Yeah. So mom, with again, it's kind of weeding through everything that's going on. But when we're doing an operative delivery, if you look at the studies, it says that there might be a little increased risk, especially with forceps. Of a higher degree maternal tear. Could be the forceps has a little increased risk of what we call that anal sphincter injury. And potentially that can lead to future things like incontinence and such. And we did a little podcast earlier about obstetrical lacerations. We talked about it there too. And so
specifically 3rd and 4th degree, so involving the anal area, not just the typical.
Right. It's because with forceps, comparing forceps and vacuum doesn't increase any the diameter of the baby coming out. Forceps does minimally, but it still does in an area where something is barely fitting anyway. So there's a little higher chance of potentially, that, potentially future pelvic floor problems, and things like that. So always a plug in for, the pelvic floor physical therapy afterwards. Yes. But so for mom, there's that. And then...
but as far as the benefit, then either there's 2 benefits. One, it expedites the delivery, right? And it's typically quicker to do that than to do a C-section by the time you get to the operating room. And this is more so if it's an issue of like babies in distress, right? Sometimes it's quicker just to do an operative birth versus to run back to the OR, because that might take another 5 to 10 minutes to get the baby out versus a few pulls and you're out, right? So, but it does avoid a C-section. Obviously, C-section has its own, risks, but it's an option. Some people are like, absolutely not. I don't want any forceps or vacuum. I'd rather do a C-section. That's okay. And some people want to avoid C-section at all costs, right? So it's an option.
Each patient has their own weight on each of these things. With vacuum, which is, again, I'm not going to disclose my preference yet.
Do you have a preference? Oh, I think
I do. Okay. Yeah. With both of these, there are risks, extremely rare. There's scary risks, but they're extremely rare. Just like if for like a VBAC delivery, there's a 1% risk of that rupture of the uterus, but it's extremely rare. And so the big thing with forceps and vacuum as a provider is I'm already pretty as certain as I can be that this baby is going to fit vaginally to the best of my ability to predict that. Because as you mentioned before, the last thing you want to do is if there is expected big baby and labor is not going correctly, and you're like, oh, okay, let's pull baby. You don't want to get yourself into probably the scariest complication that we deal with is shoulder dystocia. Do you agree?
Oh yeah, that's probably the only thing that really scares me.
Yeah, in our profession. And so that's really what you want to avoid with these things. You have to be pretty certain that baby is coming out when you do these. And I like to phrase it to patients that when I'm doing the delivery, you're still giving 100%. You're pushing as hard as you can for all of these pushes, and you're still pushing with the contractions. I'm just giving you that extra 5 to 10%, and that's usually all that's needed.
Yeah.
And it's just, it's not something a vacuum shouldn't be tried for, 30 to 40 minutes, like 50 minutes, it can take a few contractions sometimes, which if they're spaced out can be a little bit, but you don't want to force the issue with these things.
There's only one caveat to that is, I don't know if we're going to talk about like pulmonary hypertension and when mom shouldn't push.
Yeah.
That's the only time that we use it solely for.
There's some heart conditions or similar type brain spinal cord conditions where moms shouldn't create that pressure in their body to push. They can still try for the vaginal delivery. And this is a situation where actually I'm a big fan of the forceps, and I think a lot of people are because you're not having that maternal push, and so you can put more traction with forceps.
Yeah.
In a everyday situation with mom pushing, I feel like you don't need that pressure. Yeah. In a situation where the mom can't push, it's nice.
It's nice, for sure.
Because that's why I like vacuum, is because like if baby's not meant to fit, baby won't. I'm not going to force anything.
Yeah, and that's a big consideration. When you're mentioning the patient, she can't push anymore or whatever. You go in, you assess the pelvis, you make sure that there's is it an inlet, is it an outlet? Can the baby actually fit? Is the baby low enough for operative delivery? We'll talk about that later. Or if it's going to work. I mean, there are times where I'm like, this is just not going to work, and I'd rather not put that risk on, the patient or the baby. Yeah. And I think the safest would be to do a C-section. And there's been other times where maybe I'm a scaredy cat, but if I don't think the kid's coming out, I'm not going to bother with it, right? Because why?
You're just asking for trouble.
Right, exactly.
So I guess we didn't totally touch on it, how we assess somebody if they're ready for, or this is even an option. Yeah. Because if somebody, go ahead with how you assess somebody.
So, you feel for the baby, right? You feel the size of the baby, where they are. The first thing is the baby in the pelvis. Is the baby engaged? Are they still really high floating in the belly, right? Usually not, but
because I used to do forceps, things like that, which turned into a lot of really bad, unfortunate situations. And again, so luckily we don't do that.
Yeah. So for a vacuum, typically it's either
you're kind of starting to see head.
Kind of, yeah. Well, yeah, but also
not always, but
not just kappa and swelling like an actual bony part. What does the pelvis feel like? How is the pushing effort? Because if mom or a patient's pushing and nothing's happening, then how much force am I going to have to put on this kid? And how much am I going to be pulling versus pushing, right? I think and then also the position of the baby, although that's
not exactly. You like a certain position of where baby's facing.
But I think more just assessment of the pelvis.
Bladder empty.
Make sure the sutures are palpable.
I just always think of Siddiqui one of our old teachers. I wonder if he listens.
The longest vacuums, but they're pretty cool.
It's kind of like me.
I know you do a lot like him. So just feeling the pelvis and seeing where the baby is and whether or not the kid's going to budge or not. Is this even a feasible option, right? And we, at least in our hospital, we always have the NICU team present, just because you never know, babies can come out a little stunned. And I always prepare for a shoulder, because that is increasing the risk of a shoulder dystocia because of the force that we pull the baby through. So that's usually how I assess station, position, pushing effort.
Yeah.
And babies. And also, if I don't think, like I said, if it's not going to come out, don't bother. But, whenever we have an operative birth or try to, I always tell my charge to just, hey, let the OR know, because you have to also be willing to abandon the procedure if it's not working, right? Don't keep pushing and pulling if it's not going to work, right? Don't spend 2 hours trying to do this. If it's not going to budge, stop and go do the C-section.
I'm hoping this can be a podcast, which if somebody's listening, hopefully you can learn something else, help educate, if you have a friend that's pregnant or something like that, we were in the future episodes, I hope to talk about things like birth trauma. And I think if we talked about, okay, mom's tired, she wants help. That's one situation. Also a situation, sometimes these babies, they can get stressed quick and our level of concern can go up fast, potentially. And so if all of a sudden you have a bunch of people in your room, they're worried about your baby and you qualify for a vacuum, it can be hard to digest all that information and make that decision. And it can turn into this traumatic event.
Yeah. Like I didn't have time to think about this.
If somebody's like, oh, if they listen to this or they read about it or watch somebody else talk about it that's in the profession, like hopefully you can have that idea heading into your delivery. So it can hopefully be an easier decision in that difficult time.
Yeah. Yeah.
So send it to somebody if they know that, or if they, I can't even talk anymore. Send it to somebody if they're pregnant or. But we got to let Dr. Valieva go on her day off. She's got some responsibilities.
Oh. Okay, I have a few minutes.
Oh, go ahead.
Yeah. Do you want to do your forceps thingy? Or we're doing pros and cons?
I think we kind of did it along the way. I was going to say Olga's going to advocate for vacuum.
Well, it's only because I don't know how to do the other one, so I don't really have. I think had I learned, it is a useful tool because the advantages of a forcep is you can do higher. Like if the baby's at a higher station, and you can also rotate the baby a little bit. Again, I don't know. I've only read about it. I've never seen it. So this is what the books tell me.
Right.
And like those moms that can't push or the patients that can't push, like you can let the baby labor down, but then at a certain point, they're probably easier to forcep than a vacuum. But
forceps has a higher chance of success, but
it does. Yeah.
Like we said, it has a little increased chance of the lacerations. It's a little more. Somebody that's proficient in it can put it together pretty quick, but it's never going to be as quick as grabbing a vacuum and doing it.
Yeah, because it takes time to make sure they articulate and they're put together right and checking for tissue. But yeah, you're right. It does have a higher success rate.
It does. And it overall, again, still very safe, but it does have some of those risks. I
have to say, I think vacuums and shoulder dystocias actually get my heart going.
Vacuum's a nice little. It's an adrenaline rush. A lot of everything. Patients have been pushing for a while. Everything's culminating into this one big event, and
everybody's staring at you,
and everybody's staring in front of you and behind you, and so I like it.
Of course you do. Yeah,
pretty successful.
And then as far as the tears too, I know. Something about it, I don't know if we're going to touch on it. What I'm going to touch on is the episiotomies. They used to routinely do episiotomies for these to make room. It's, again, fallen out of favor and only if you really need to. But as far as the tears, if you do have a tear, most of them, the incontinence risk of both fecal, flatus, urinary, that tends to resolve within the first year. And with the studies they've looked at after 5 years, they don't have any long-term issues. I mean, is that to say that when they're 50, they won't have issues again? Hard to say, right? But in the immediate future, it's kind of a wash.
Yeah. Luckily, young, healthy women heal well. And so, these areas heal well. There's these risks that we talk about, and by far, a majority of people don't experience that, luckily. Yeah,
but don't be scared to talk to your providers about it. I mean, bring it up, and especially if you're talking about a birth plan or like what's going to happen during my birth if it's your first time.
Because people will often put on their birth plan, absolutely not, I don't want this. But because it sounds scary.
Sure.
But let's talk about it.
Yeah.
So.
Yeah. Did we cover it?
We did. I think we did. How long does it take?
Oh, it depends.
We touched a little bit. Like, let's talk vacuum because that's what we often do. It can take, if baby's sitting right there, it can take 10 seconds.
Yeah, barely a pull.
It could take a few contractions. And if those contractions are spaced and everything else is looking good, you can, wait a few contractions. So it could take 10 to 15 minutes.
If there's progress, you can keep going, right? Yeah.
And so just the weight of, how everything's going. And you always have a say in whether or not you want this. If there's significant concern for baby and you don't want this, the alternative is likely C-section unless that baby is really close to delivery. So
I hate that C-section after a vacuum though.
Yeah.
That baby gets wedged.
And how moms are feeling these physically when we do these.
Hopefully they have good pain control, but it shouldn't be any. I shouldn't
it's a little
say
more
that,
expedited.
It could be,
Yeah.
But it can be a little bit more painful, especially when you're going in there and feeling for the position of the baby in the head. So you're putting extra things inside the vaginal
And I
canal. So
imagine
that can be.
so we're talking about epidurals here. And so if somebody has an epidural, likely, hopefully your pain control is a little bit better. You're not feeling a ton increased sensation. But with that crowning of baby,
Oh,
even with an epidural, the ring of fire feel, you're probably still going to get that. It might be a little more intense than just kind of maybe pushing baby out on your own potentially. It's hard to put a number to that. Forceps, if you don't have an epidural, I imagine would be a little, again, you're introducing something more so. Might be a little more sensation with those. So yeah, both, they're a little different maybe in that way, but I don't think we have any studies supporting that.
Have you done only Kiwi cups, or have you done other cups too?
There was one other one that we had that was the more of like the
Milwaukee?
squishy. No,
Yeah.
I think
They have it here. I don't think they have.
I can't remember if it was here in Kansas City or Milwaukee.
I knew they had. Two
They had it.
different
I didn't
ones.
like it. Somebody really did.
'Cause you can turn
McGinnis
it-
liked
yes,
it.
Yeah, it was Milwaukee because it was rigid, so you can
Yeah.
like rotate the baby.
Yeah.
Yeah, I don't like it.
So, Dr. McGinnis, if you're watching that,
Kudos.
enjoyed learning
Could not
from you.
figure it out.
Did not like your vacuum.
Teach their own. You got to find what works for you, right?
We kind of batted around a whole bunch here in this podcast, but I hope you enjoyed it. I hope you learned something. Send it to somebody if you feel like they could benefit from this, because it is a nice little conversation to have because, like we said, things in labor, we hope for the, smooth little labor, but there can be, some, we can't always control how baby is going to tolerate things like that. Anyway, don't blame it on the babies.
No, blame it on the babies. It takes the guilt out of it. Or when in doubt, don't get pregnant. I'm just
And
kidding.
that's
I'm
it
kidding.
for
I'm
today's
kidding.
podcast. Thank you for listening and viewing. If you have any questions, please let us know in the YouTube comments. As always, content of the podcast and video are for educational purposes only. If you have any needed medical advice, then talk to your provider. So, all right. Bye, everyone. Thanks.
Deuces.